I'm Stacy. So we're going to go over the other derm lectures. So ulcers, burns and wounds, and then emergent pediatric burn care, and then again, complex wounds. So I've put the wounds and I've put the burns together and then the wounds together, and then we'll do ulcers. Okay, let's get started. Oh, also make sure that you check out my GI videos. Those are all up to date. They're all up. Okay. So let's look at ulcers. So we've got really three types of ulcers, and I would know the difference between these. So venous is going to be more at the location of the malleolus, above the bony prominences. Arterial, it's going to be more over pressure points, the base of the hill. It can be over the malleoli, but over joints, over the anterior shin, is more likely than the malleoli. Neuropathic, it's going to be on the bottom of the foot, on the plantar surface, and over the metatarsal heads or those pressure points on the bottom of the foot. So let's talk about the appearance. So for venous, there's going to be irregular margins. It's going to look pink to red. It'll have a yellow, fibrous, granular looking tissue, and there might be some exudate. Arterial, there's going to be irregular margins, just like venous, but the base is going to be dry, and it's either going to look pale or necrotic. So you can see in the picture that there's that area of central necrosis where the venous section looked more fibrous. Neuropathic is going to be look like a punched out ulcer. It's going to go from superficial to deep. It's on top of a callus many times, and it's going to have that red base. So there's pain with venous and arterial, but not with neuropathic, because now we're affecting the nerves. They're not working properly, so we're not going to feel pain. Just like our nerves aren't working, we're not going to have a reflex with neuropathic, but we will with venous and arterial. So I would know the difference between these types and be able to identify it on an exam, especially if they give you a picture. Okay, so there are stages of ulceration. It's that localized injury to the skin overlying a bony prominences due to a risk of pressure or pressure and shear. So stage 1 is going to be intact skin. It's darkly pigmented. Stage 2 is going to be that partial thickness, loss of the dermis, and it'll have that open ulcer. Stage 3 is a full thickness tissue loss, and subcutaneous fat may be visible, but not the bone. Tendon or muscle are exposed. And stage 4 is going to be full thickness tissue loss with exposed tendon or muscle. Eschar also may be present. So make sure that you know the difference. So stage 1, darkly pigmented. Stage 2, partial loss of dermis with an ulcer. Stage 3 is going to be full thickness, but we're not going to see bone or muscle or tendons. Stage 4, we see pretty much everything. Okay, infection assessment. So there's like 2 different criteria. Either you have to be positive for 3 of the criteria: non-healing, exudative, red bleeds, debris, or smells, or you can use the criteria of it's increasing in size and temperature. You can probe or see the bone. There's a new area of breakdown. It's exudative, erythematous, edematous, and has a smell. So wound cultures, she talked about 2 different types, Levine or Z technique. Basically, you just have to get in there and get a really good culture. You can't just like probe it. You really need to sort of like stir it up and make sure that you actually get the infection and not just like skin flora. Okay, so ulcer types and treatments. It's basically looking at that same slide that we had just looked at again, except we're looking at treatment. So I included the same locations just to remember. So for a venous ulcer, compression, elevation, exercise, a statin such as simvastatin, and then wound care. Arterial, you want to increase blood flow to the area. So graduated exercise programs. fix the arterial problem with an angioplasty stent, or maybe they need a cardiac bypass or an arterial bypass. And then wound care as well. Diabetic or pressure ulcers, compression, exercise, hyperbaric oxygen. So hyperbaric oxygen is a really cool thing that wound care does. So they can either put a person's, like, let's say leg for this example, or their entire body in this oxygen chamber, and it helps with healing. Offloading. So let's say an exercise program like swimming would be more helpful than or like putting pressure on the other leg instead of on this section of pressure would help. Again, I said swimming, and then I'm thinking about like moisture balance, like you don't want it to be too wet. Wound care, nutrition, and then control the moisture. So like decreasing the moisture. If it has a ton of moisture, it's diabetic. We were thinking like maybe Pseudomonas. So you don't want to get infection on top of that. So control that moisture. So with wound care, there's like a little mnemonic called TIME, tissue debridement, infection control, moisture balance, and edges of the wound. So when I was on a trauma service, I got to help every day with this guy packing his wound and wound debridement of this huge anterior shin wound. So he like hated getting it packed because it's super painful and you really can't like numb that area. But a lot of times with like wound debridement, it's dead skin, like they can't feel it. And it really helps. They get like sad at first and scared, but really it's okay. Okay, so let's start talking about burns. So you need to initially remove all clothes. They could have something on it that continues to burn the skin. So this patient got in a car accident, or they got in an accident with a lawnmower. It turned over on her, and all of the gas from the lawnmower was on her. And so all of that clothing that was on her continues to burn the skin. So basically you just have to get them naked. So you need to stop the burning process. Don't use ice, use like water on a blanket, and like use water to get all of that, to get whatever's on them off. It's really important to prevent hypothermia. So cover them with warm dressings, increase the ambient air, warm IV fluids. So like in a trauma situation, in the ER, in one of the trauma rooms, those rooms are super duper hot. And they've got it's almost like, looks like a little refrigerator, but instead it warms blankets. And it's really important that usually they're shaking and they're super cold. So make sure that you cover them. Warm IV fluids, really helpful. Airway management, inhalation, injuries, immediately you have to intubate. Edema evolves over 1 to 2 days. So they initially may be breathing okay, but later on they're not. Inhalation, thermal, they'll have that hoarse, raspy voice. Carbon dioxide or carbon monoxide poisoning, they'll have hypoxia or anoxia. Chemicals and irritants, just know that it's later in the course. Okay, so this is super duper important. I included 2 stars. So at our index of suspicion, this 100% will be a question. So when you see a question, and it could be on your boards too, think of these 4 areas and go by a point system. So physical assessment, how's their respiratory status? Where was the fire? And how is their mental status? If you can read a question and quickly come up with points, it's a super quick question, super easy, as long as you memorize it, and it'll get you points on the test. So for physical assessment, look, do they have facial burns? Look at their nose. Is there singed nasal hair? If there is, that gives us a point. Look at their respiratory status. Were they inside? Were they inhaling smoke in an enclosed space? That gives us a point. If they're outside, then it's not as important because it's not enclosed. It's a big space. So the respiratory status is probably okay. Location of the fire. Are they hoarse? Are they, do they have, I've got these two backwards, but so location of the fire should be inside or outside. Respiratory status, are they hoarse? Are they, do they have stridor? Did they have black looking sputum? That gives us a point. Mental status, are they awake and alert, or are they confused or obtunded? If they're confused, obtunded, that gives us a point. So if we have 3 points, it's going to be moderate. If we have 4 points, it's high. And if we've got that high index of suspicion, it's very important to go ahead and intubate the patient. Okay, so burn shock edema. This increases capillary permeability. It's an inflammatory process that increases edema. The treatment of this is going to be escarotomy. If we've got a huge burn, it's very important to be doing this escarotomy. Let's say that it's on their chest. This patient, it's going to like decrease the patient's ability to breathe. So think about putting on, it's like putting on a big restricting device. It's like a big, huge bear hug. The patient would not be able to breathe if they are not able to use their accessory muscles because there's something constricting their breathing ability. So it's important to do this escarotomy so that they have the ability to move and to breathe, and it relieves that pressure. In another situation, if it's not the chest, it could result in compartment syndrome because there's nowhere for the edema to go. So this is super duper important and for sure will be a test question. Okay, calculating burn size, another super important thing to do. So you can use the rule of nines method. That's the method, sadly, that will be on board exams and that somebody will ask you about. The best method, however, is the Palmar method. So you use their palm, not yours. So if it's a kid, obviously they've got a smaller palm than you. And their palm is about 1% of the total body surface area. So the example in the picture, you kind of have to estimate and guess. It's about 7%. If there is greater than 20%, they need an IV, get them some fluids, and they need to be intubated because they may be okay. They may be breathing right now, but later, maybe not. And right now, while you have the ability to intubate them in their larynx and pharynx is not edematous and closing, it would be easier to intubate now. So make sure greater than 20% intubate and needs an IV. If they're greater than 65 or less than 2, they also need fluids. Lactate ringer is usually the fluid of choice. Initially, you take their percent total body surface area of the burn and you times it by 10. And that is the initial fluid requirements given at milliliters per hour. A lot of times people use the Parkland formula for continuation of fluid, which is 4 times their kilograms times their percent total body surface area. And you're going to adjust fluids based on their urine output. So if they're peeing a lot, you can decrease the fluid. If they're not peeing, you got to increase it. Okay, so here's some types of burns. I didn't think it was like super important, but I just included it for your information. Tar, you need to cool the tar and stop the burning process. Use petroleum-based ointment to emulsify the tar. I thought maybe that one would be maybe the most important. Scald injuries are usually in children. It happens really quickly. Grease usually is greater than 350 degrees, like deep frying oil. Non-accidental. If you see a burn that doesn't make sense, report it to CPS. Classic dip burns have no splash marks and clear demarcation. Flash burns are going to increase the heat for a short period of time, and the clothing can be protective unless it's on fire. Flame burns, deep dermal, full thickness burns. Chemical basic is going to be worse. It kind of creates the soup with the lipids in your body, and it dissolves the tissue. Acid's better, and it damages by necrosis. Electrical, there's going to be arc flash that can then go to the blast, which when it combines with the air. Look for Lichtenberg figures, which is a fern-like pattern on the skin with a lightning strike. And treatment for all of these, except the tar, would be continuous flushing. Okay, so let's know the degrees of burns. First degree burn is a sunburn. It involves the epidermis. It's red, painful, no blisters, and no scarring. Do not calculate your percent burn total of total body surface area for first degree burns. That is a classic trick that they could ask you on an exam. They have first degree burn and it asks you what the percent is, but know that you do not calculate it. So if the answer is none of the above, or the answer is cannot calculate, that is the answer. So do not calculate burn size for first degree burns. Okay, second degree burns involves the epidermis dermis and is partial thickness burn. They've got painful red blisters. Treatment's going to be bacitracin on non-adherent dressing. A lot of docs in the past used to use Silvadene cream, but that's not the drug of choice anymore. It's Baci. Third degree burns are going to involve the epidermis dermis and are full thickness burns. There's no pain. It's killed those receptors. It usually has a white and it's not going to heal, unlike the other ones. Treatment is going to be escarotomy across the joints, and later they're going to get a graft. So that guy that I talked about that had that terrible infection, he also he got a graft later. So it was kind of cool that I got to help make the graft and then and sew it on him and then get to see the whole process later. So it was really cool. Fourth degree burns are into this cutaneous and subcutaneous and soft tissues. It involves vessels, nerves, muscles, bones, and joints. Okay, so know that second degree is partial thickness. Third degree is full thickness. Second degree, we use Baci. Third degree, escarotomy. Okay, so let's look at wounds. This is our last section. So hairy nevuses, it grows with you, so they are going to get bigger as the child grows. They can be large or small. So in the first picture, we've got a small one. In the picture on the right, we've got large. This with the large one can have many satellite lesions. So you see these like really big ones, and then we have all these other ones as well. More than half of those that have these hairy nevuses will have a risk of melanoma than the general population. And treatment is to remove them so that they don't have that risk as much. Okay, dog bites. It's usually from the more aggressive dog types like pit bulls or Rottweilers. 61% of deaths occur under age 4 from dog bites. Watch your kids, watch your dogs. You know, you may think, well, my dog is so sweet, but kids, you know, they don't understand. Sometimes they'll like pull a dog's tail or they'll put their hands near their mouth. And, you know, maybe your dog is not mean, but it just doesn't understand that this is a child and they don't understand what they're doing. So it's just important, you know, to watch kids and watch dogs, you know, and don't just assume that everything will be okay. You can get a Pasteurella infection from dog bites, but you can't close these wounds due to infection risk from Pasteurella. You can graft later, and remember, this wasn't in the slides, but I thought it's important. Remember that you can treat with Dogmentin, which is Augmentin. It's amoxicillin with clavulanic acid. Hidradenitis suppurativa is going to be chronic relapsing inflammatory disease of the apocrine sweat glands. It involves the adjacent skin and tissue. There's going to be abscesses, fistula, and fibrosis. It's really painful, smelly, shown in the picture of the axilla. The most common location is axilla, but then there's also inguinal and breast. Etiology is going to be like deodorants getting in there, shaving, smoking, obesity, and genetics. Treatment, there's a lot of treatment option, but really excision and grafting are the best options. Necrotizing fasciitis is the flesh-eating disease. It's a bacterial infection at the site of trauma or skin tear. It's sudden onset. A fourth to a third result in mortality. They may develop sepsis, they may need life support. You might see these in question stems. Treatment is going to be autograft, and the main cause of the reason that autograft fails is that the excision was not deep enough. So important to know. Okay, Purpura Fulminans is, there's 3 types. Neonatal is lack of protein C, idiopathic, and then infectious caused by staph pyrogenes, Neisseria meningitis, and Mrsa. Presentation is going to be that rapid necrotic purpuric tissue, fever, hypotension, and DIC, and multi-organ failure. So if you start seeing this and they start going and you see this rapid necrotic purple tissue and they start going towards shock, know that it's Purpura Fulminans. Treatment for neonatal is going to be FFP and then a lifetime of anticoagulation. If it's idiopathic or infectious, we're going to treat the infection with aggressive antibiotics, and then treat like shock, volume resuscitation, ventilation, and inotropes. And you may have to amputate, like in this picture. They had to amputate that leg. And once they amputate and start using these other methods, then the patient starts to get better and improve. Staph scalded skin syndrome, the quadruple S, is a exfoliative toxin produced by Staph aureus. Common sites are going to be mouth, nose, throat, umbilicus. It's common in the NICU. The presentation is going to be that they had a history of infection like strep throat or impetigo. They're going to have fever and malaise and a rash. Treatment's going to be antibiotics, hydration, and wound care. So I actually saw a patient in outpatient peds with staph scalded skin syndrome. So of course we immediately sent them to the nearest pediatric hospital because they are going to have to go to the ICU. Okay, so I think this is super, super duper important. Erythema multiforme, Stevens-Johnson syndrome, and toxic epidermal necrolysis. So basically it's going to be, they're all pretty much the same, except it's the percent of total body surface area. So erythema multiforme is going to be a localized eruption. They've got those target shaped lesions, and they have usually no mucosal involvement. They're going to have less than 10% of their total body surface area. Stevens-Johnson syndrome is going to have that less than 10% of total body surface area that's involved, where toxic epidermal necrolysis is going to be greater than 30%. That's the stuff that I would know for this. Both of these have mucosal involvement. So cause for erythema multiforme is going to be bacterial or viral. So they're going to have a toxidrome of fever, malaise, cough, and joint pain before this shows up. They're going to have all of that, and then they're going to have these target-shaped lesions show up, usually on the thighs. So if you see that, think it's EM. If they've taken a drug and then started to have this reaction with this skin sloughing, then think, okay, it's either Stevens-Johnson syndrome or 10. We've already learned how to calculate the surface area with our palm, with the patient's palm. So if it's less than 10% or, very limited in area, then think Stevens-Johnson. If it's a large area, it's going to be toxic epidermal necrolysis. The treatment is going to really depend on how bad it really is. So I'm going to, is how bad it is. So erythema multiforme is going to be, to go away sort of on its own, where Stevens-Johnson syndrome and toxic epidermal necrolysis, they may need life support. They'll need fluids. They'll need like all of the shock treatment. They'll probably need to be intubated. They'll need foods, or they'll need like feeds, like maybe tube feeds or like TPN. Okay, so drugs associated with Stevens-Johnson syndrome and TENS. There's 2 ways of remembering it. So scalpel or soaps. sulfonamides, oral hypoglycemics, anticonvulsants, antibiotics, penicillin, phenytoin, and NSAIDs could trigger this Stevens-Johnson syndrome or TENS. Know that like for pharm, probably penicillin and sulfa are going to be some of the most important antibiotics. Anticonvulsants, phenytoin, carbamazepine, lamotrigine would be most important. Also, allopurinol might be one of those things that pop up on your chest. Okay, wound healing, I didn't think was as important, but basically in normal wound healing, we have coagulation, which is where the platelets adhere and results goes to the clotting cascade. Then we go to inflammation, where we have that attraction of leukocytes, neutrophils, and macrophages. And then we go to that proliferation and granulation formation with that cellular migration and that initial epithelialization. And then we go to remodeling, where there's fibroblasts and that matrix forms within collagen and fibrin. We have apoptosis of the things that we don't need, and scar formation. Know that chronic wounds, they've got this terrible cycle of necrosis, infection, elevated pressure, insufficient metabolism, and poor perfusion. They usually have more biofilms, excessive proteolysis impaired, angiogenesis. So I think that this is all of our slides. I included an antibiotic review at the end of the slides for you to go over all of the antibiotics for pharm. Okay, so I hope you do well on your exam.